Hi, I'm Dr. Lucinda Bateman, Medical Director at the Bateman Horn Center. Today I will be delivering a lecture on treating the chronic widespread pain of fibromyalgia and ME/CFS. I want to start with a little background about our approach for the general approach to managing these illnesses with supportive care. The first very important principle is that you have seen your physician or physicians or other medical providers to be sure a good differential diagnosis has been completed to identify and address all of the other comorbid conditions or other illnesses that might be contributing to your symptoms. Then the first cardinal management of these illnesses is pacing. So it's very important that you become skilled with pacing, and that is going to control and help you manage almost all of the symptoms of the illness. Then number 3 tells the major illness manifestations that need to be addressed, and I can tell you that pain is one of the main ones, and I've lit it up there in red. So if pain is a limiting feature of your illness, something that is a stressor, then it's very important that you deal with the pain. Chronic widespread pain is present by definition in fibromyalgia, and it's very common in ME/CFS, especially as a manifestation of post-exertional malaise, or PEM. Pain itself is highly variable in terms of the cause, the type of pain, and the treatment for pain. Chronic pain usually responds to treatment, but it may be very difficult to cure and completely eliminate. Keep in mind that pain specialists, physiatrists, and other people who have expertise in dealing with pain might bring a very important component to your pain management. First, I want to talk about how to assess and treat different types of pain that might respond to different treatments. The first 2 I have highlighted in yellow, and that is osteoarthritis and other inflammatory conditions that might cause arthritis or areas of inflammation that contribute to pain. Rheumatoid arthritis, lupus, gout, and many other conditions you might think of being managed by a rheumatologist. Osteoarthritis and inflammatory conditions respond to low-impact exercise and gentle range of motion activities. They respond to anti-inflammatories, and that includes the non-steroidal anti-inflammatories, NSAIDs, and COX-2 drugs such as Celebrex. Remember that there are differences in these drugs, and they may be not well tolerated for other reasons, but usually inflammatory pain responds well to them. Corticosteroids are very effective for inflammatory pain, but they're really only safe for short-term use. It's nice because in addition to oral, there are injectable and even topical forms of corticosteroids that might be valuable. And actually, you can get topical anti-inflammatories as well in the form of Voltaren gel. The next large category of drugs used to treat inflammatory disorders are immune-suppressing or targeted agents, such as used by rheumatologists to treat inflammatory arthritis. It really requires a specialist to deal with those drugs and the potential toxicities, but at times they can be proven valuable in managing the inflammation and the consequences of the inflammation. Now, when it comes to the spine, the whole level of your spine, cervical, thoracic, and lumbar, you are dealing with a combination of types of pain. You may have osteoarthritis of the small joints, you may have nerve pain from nerve compression, and you may have muscle spasm from signaling from the nerve. This is a picture of a spine, of 2 vertebral bodies on the left, showing where they are connected by a spongy disc, And if you look at the hole that you can see, the window you can see through, it's labeled intervertebral foramen. And sometimes we call that the lateral foramen. Foramen just means a passageway or a hole. That is where the nerves exit the spinal cord. And if you look at the diagram on the right, you can see the window that is where is the spinal canal, or where the spinal cord goes up and down in your back. And what I want to show you on the next picture is that the curvature of your spine and the area of your spine may make certain areas more prone to these kinds of sources of pain. For example, the cervical spine has, you can see, has a curvature that is opposite to the thoracic spine and is more similar down in the lumbar spine. And that is probably the reason people have more problems with their cervical and their lumbar spine. And here's why. If you look at the diagram in this picture, you can see that if these were vertebrae in your neck, when you bend your neck forward, it opens the lateral foramen and allows more room for the nerve to exit. If you extend your neck, it closes the lateral foramen a little bit and can put compression on the nerve. So the reason this is important is you can learn how to adjust your body position and posture and reduce pain coming from nerve compression in your lumbar and your cervical spine, and to some degree in the thoracic spine as well. The next thing I want to emphasize is the interface of each vertebrae above, where you can see labeled on the right, called a facet joint. This is actually a small joint, similar to all the other joints in your body, and those are subject to osteoarthritis. And think of that, there's one on each side and for the entire level of your spine. This is called facet arthritis, and it responds more like arthritic joints. It can be, you can have steroids injected into it. It feels better if it is subjected to range of motion activities and involved in light activity. If you have narrowing of the lateral foramen, that's called stenosis. And if you have narrowing of the central canal, that's also called central stenosis, or a narrowing of that window or the opening. Those create a little bit of a problem in terms of crowding the spinal cord or crowding the exiting nerve. When mild nerve compression occurs, it can cause muscle spasm and it can cause nerve pain. If you have mild compression of, let's say, the nerve root coming out the lateral foramen, it might send signals down the nerve that cause muscle spasm. When you have moderate compression on that nerve, it might cause numbness and tingling and symptoms that are sensory in the where that nerve travels to in the skin. As long as that's intermittent, that's okay. But if those symptoms become persistent, then you may want to do further investigation to understand how much the nerve is being compressed. One interesting thing is that if you have fibromyalgia, or if you have ME, CFS, and meet criteria for fibromyalgia, or experience hyperalgesia, that's pain amplification, a tiny irritation of the nerve root can send signals that cause sensory symptoms. More moderate to severe compression of a nerve can result in increased or decreased reflexes and eventually loss of motor function or weakness in the muscles where those nerves travel. So as long as symptoms are brief and intermittent and tend to resolve if you change position, it's less of a signal maybe to consider going to a specialist or having surgery. All aspects of spine disease pain can be worsened by pain amplification, whether it's the osteoarthritis, nerve compression, muscle spasm, all of those can create increased pain. So I'm going to leave the inflammatory disorders and the complex kind of pain origins in the spine and talk about all the other conditions here that have a yellow highlighter. And I'm going to read them together with you on the screen. So hyperalgesia is the term that means increased pain and increased pain signaling. And that causes generalized pain and pain amplification. And not only in fibromyalgia, but in many conditions. Headaches, especially tension or chronic daily headaches, are a type of chronic pain problem that can be thorny and not respond easily to the medications we've discussed already. Certainly migraine headaches can be complicated and difficult, might require a specialist. Interstitial cystitis, irritable bowel syndrome, pelvic pain, and many of the what we think of as comorbidities with fibromyalgia might be related simply to pain amplification in those different areas of the body. And that is important to know because often it will respond to the same type of medications we use to treat hyperalgesia in other settings. Now, neuropathies are the type of pain that develops when a nerve has been injured, perhaps from exposures or trauma to anything that is damaging to the nerve. The thing we think most commonly about is type 2 diabetes and peripheral neuropathy, but there are many other conditions where peripheral neuropathy can develop. This involves the very longest, most fragile nerves in your body as they get longer and longer, as they go from your spine all the way to their destination for the job that that nerve does. So they're the most prone to injury. Also, the small fibers, the very small fiber nerves in your body, the ones that are in the skin for picking up sensation, and the many small nerves that dilate or constrict smooth muscle, such as in around your blood vessels or other tubes in your body. And also the autonomic nervous system is made up of small fibers. And these are the kinds of nerves that are vulnerable. You know, I want to make you familiar with the terms. Neuralgia means pain from a nerve. Arthralgia means pain involving a joint. And myalgia is pain originating or being sensed in the muscle. This is a picture drawn by one of my patients in clinic. The black marks were drawn there by the medical provider to indicate where the tender points were. And the red marks are those drawn by the patient to try to communicate the nature and the location of widespread pain. And you can see in a pain diagram very clearly the widespread nature in fibromyalgia. Now, this patient did a pain diagram in my clinic. You can see that the pain is widespread and it's in all 4 quadrants of the body. But note that the strongest red are in the 4 extremities. This patient has a severe peripheral neuropathy involving the arms and the legs, low back pain, and myofascial pain involving the head, neck, shoulder area, irritable bowel, can you see the colon drawn in there, and headaches. So this person has a very severe chronic pain problem that is maybe compounding or in addition to generalized hyperalgesia, fibromyalgia. It's important to know because if someone has a peripheral neuropathy, it's important to investigate what's causing it, what underlies the peripheral neuropathy, because it might be reversible, or you can at least stop the further progression of damage in many cases. This is a diagram that is very descriptive. You can see there's a diagram of a knife, a stabbing pain in the back. There is a diagram of a bed of nails that the person is standing on, and you can see that there are many pain areas, a combination of widespread hyperalgesia of fibromyalgia, plus myofascial pain of the head, neck, shoulders, low back pain, and one knee that's arthritic. But you can see how a pain diagram helps communicate to a doctor the location of your pain, and even if you don't know the significance of the location, it's possible that your medical provider will understand more about the underpinnings of your pain by viewing your pain diagram. We diagnose fibromyalgia using the American College of Rheumatology criteria from 1990 with very simple criteria. And you can decide if you have fibromyalgia or meet criteria. Number one is the pain must be chronic, and that is defined as more than 3 months in duration. Second, the pain must be widespread, involving at least 4 quadrants of the body. And the third criteria is that you must experience tenderness. Tenderness is a physical exam finding, and it means that when you push on something, it elicits pain. So chronic, widespread pain, and tenderness. Those are the criteria for fibromyalgia using the 1990 criteria. These criteria, or this syndrome, can occur in the presence of many other diseases. So it's important to know if you meet fibromyalgia criteria, in part because it responds to medications in a different way. So, for example, if a patient has rheumatoid arthritis, the treatment is going to be using anti-inflammatory drugs, range of motion, etc., maybe even immune modulators. If generalized hyperalgesia is superimposed on rheumatoid arthritis, that pain is going to respond in a different way than inflammatory pain. We know that fibromyalgia is a very common comorbid condition to almost all inflammatory diseases. Also, it can occur in many other settings, particularly sleep disorders and problems with hormones. So the hyperalgesia can be manifest in many ways: stiffness and pain in the muscles, joints, headaches, bowel, bladder, pelvis, chest, paresthesias, that's the medical term for numbness and tingling, even something like photophobia, which is sensitivity to bright light, is considered on the spectrum of pain amplification. This diagram shows the areas of pain of this patient and how this meets the criteria that 4 quadrants of the body and the spine need to be involved to call it fibromyalgia. So for all kinds of pain, it is important to become skilled in utilizing lifestyle adjustments. We know, well, I think it's a common knowledge to everybody that preventive and maintenance strategies are effective, safe, and inexpensive. And all the things you do behaviorally that might reduce pain, almost all can promote better health in general. Now, these are important secrets and pearls, and we'll go through them, and I hope they resonate with you. We'll be talking about medications and other interventions in a few minutes, but these are things that you can do on your own to help with pain. Number one is particularly we're talking about hyperalgesia now. Hyperalgesia responds to restorative sleep. Sometimes just putting restorative sleep in motion will reduce and eliminate hyperalgesia, especially in the early stages. The longer you have hyperalgesia, the more it is difficult to eliminate it. But almost every person with fibromyalgia and ME/CFS patients who have hyperalgesia will attest that the better the sleep, the more restorative the sleep on a general basis, the more the pain amplification can settle. Second, relaxation. Anything that calms the central nervous system, meditation, mindfulness, emotional calm, even mental distraction where you take the focus away from the pain. These are all effective modalities to improve your ability to manage pain. They must be done from the inside, and it's not easy to be calm or relaxed when you're suffering from pain. But the more you can learn how to apply these practices in your own life, the more you can have periods of respite from your pain. You may not eliminate it, but it is very likely that you will be able to have rest periods or respite or times when you get some relief, at least from the severity of the pain. Now we know that physical activity has a big impact on pain, but that goes on both ends. Men, especially hyperalgesia, if you don't do enough activity and are too sedentary, there will be more stiffness and achiness in the joints and muscles. Of course, if you do too much activity and you don't make your exercise low impact, then the pain can escalate. And pain can certainly escalate in conditions of hyperalgesia if the activity is too intense or too prolonged. So you can let pain be your guide about how much and how intense, but you need to try to do as much as you can to keep the joints or the muscles in motion and reduce the stiffness and the atrophy of muscles. Many studies have shown that manual methods, massage, acupuncture, acupressure, and many different practices can help provide temporary or, in some cases, longer relief from certain kinds of pain. And warm baths and other relaxation techniques that involve soaks and warm fluids can also be very helpful. Now, let's talk a little bit about medications. This is not for you to prescribe medications for yourself, but to understand the range of medications that can be utilized in partnership with your medical provider. They may not have a habit of using this broad range of medicines. Sometimes we get our favorite 1 or 2 medicines and don't realize there's a broader array. So I'd like to make you aware of the different kinds of medications so that you can open a conversation with your medical provider if that feels appropriate to you. So first, there are the FDA-approved drugs for fibromyalgia, a condition of hyperalgesia. There is one anticonvulsant, pregabalin, that is marketed under the name Lyrica, and there are 2 SNRIs, that's serotonin norepinephrine reuptake inhibitor. The 2 that are approved are duloxetine, which was marketed originally as Cymbalta, and the second is milnacipran, that is marketed as Savella. The SNRIs, Savella and Cymbalta, along with Lyrica, have an FDA indication. That means large studies have been done to show safety and efficacy in reducing hyperalgesia. That doesn't mean there aren't a lot of other drugs. There are non-FDA approved drugs that your doctor can use clinical knowledge to determine whether it would be appropriate to use in your case off-label. There are a number of anticonvulsants similar to Lyrica. One is commonly understood, that's gabapentin. Topiramate or Topamax is a drug that is actually FDA approved for migraines, another condition of hyperalgesia, but may help with generalized hyperalgesia in some cases. I put topiramate and zonisamide together because those are the 2 anticonvulsants that don't contribute to weight gain. And that doesn't mean they're as effective at reducing hyperalgesia, but it gives more options for people who perhaps have a tendency to gain weight on some of the more effective anticonvulsants for pain. There are other SNRI drugs that you can discuss with your physician. We often use low-dose TCAs, that's tricyclic antidepressants, amitriptyline, nortriptyline, doxepin. These are familiar to your doctor. They're used for sleep sometimes, for migraine prevention, and other modalities, including the treatment of fibromyalgia off-label. There are a number of muscle relaxants. One called cyclobenzaprine, marketed originally as Flexeril, has features of the tricyclic antidepressants, but also works as a muscle relaxant. So it might help you sleep, it might reduce pain generally, and it might reduce muscle spasm and some of the consequences of nerve compression or nerve damage on the muscles. Next in the line is a list of drugs that are related to opioids. Tramadol is the first one. It's not traditional opioid. It's a drug that works on both serotonin pathways and with opioid receptors. That would be considered maybe the first line of drugs that go toward opioids. Then buprenorphine is a drug that's a mixed agonist-antagonist. That means it both triggers the opioid receptors and it blocks. And you might be familiar with Suboxone, but there are other drugs in this category. And then I've listed several other kinds of opioids that might be used in this situation. I'll speak more about the opioids in the next few slides. The last item on the medications is low-dose naltrexone, or LDN, and I'll talk about that more in a moment. It's important to note that topical agents can be helpful for pain across many different types of drugs. For example, lidocaine, which numbs the nerves, diclofenac, which is an anti-inflammatory, and is delivered effectively through the skin to nearby joints that are not too far beneath the surface, and anticonvulsants like gabapentin. Probably the most important lesson we've learned in the last decade or so is that opioids used daily to manage pain can actually, to manage hyperalgesia, let me be clear, they quickly become ineffective and actually increase the hyperalgesia over time. So it's really not a good first choice for people with fibromyalgia and widespread hyperalgesia because it takes a larger amount of opioid to reduce the pain. You develop tolerance to the drug very quickly. And when you try to remove the drug, the withdrawal is very miserable, and it's like an escalation of hyperalgesia. And in addition, when you come off the opioids, your primary hyperalgesia might be worse than when you started. So we're trying to avoid going down the path of using opioids in the setting of hyperalgesia and fibromyalgia. Now let's talk about LDN for a minute. Naltrexone hydrochloride is an opioid receptor antagonist. The FDA has approved a 50 milligram capsule of naltrexone for the treatment of alcohol and opioid dependence. But a very wonderful person, Jared Younger, that you may have read about or understand, has published some articles and is continuing to do research on how very low doses of naltrexone might actually, in some paradoxical way, decrease pain and also act on microglial cells in the central nervous system. These are cells involved in innate immunity in your brain and spinal cord. And glial cells react to the presence of danger to the nerve cells, release inflammatory molecules and change, and become, maybe in the effort to protect nerve cells, may actually cause some collateral damage. Naltrexone seems to calm those microglial cells down so they go back into a more quiescent state or a quiet state. And that may be, although we have a lot to learn, the mechanisms underlying why low-dose naltrexone can help with hyperalgesia. It's important to know, and we'll go through the list here, it works gradually. You should observe for 2 or 3 months to determine its efficacy. Most generally take low-dose naltrexone at bedtime. It's a generic drug, but because it's not made in a pill smaller than the 50 milligram pill, you need a prescription to go to a compounding pharmacy to make a much smaller dose, something between maybe a half milligram all the way up to 5 milligrams. Some people find that low-dose naltrexone is a little disruptive of sleep, maybe because of dreams, and other people feel like it helps them sleep. So, but either way, usually that kind of a short-term side effect of the drug usually resolves. It's also important to know that naltrexone really shouldn't be used in combination with other opioids, because they actually work in opposite ways, and neither one would have maximum ability to do its job if used in combination. So it just doesn't make sense. So those who are going to try or go on low-dose naltrexone need to make a commitment to stay off the opioids until they make a decision about whether naltrexone is going to be effective for reducing their hyperalgesia. And it's good to know that if you are anticipating surgery, dental work, or something that is highly likely to require the use of opioids, you should inform your providers and stop the low-dose naltrexone in anticipation. In emergency situations, they should also know that you're on low-dose naltrexone because it might require higher doses of opioids to achieve the same pain relief. All medications work better and work longer in combination with effective lifestyle changes. So generally, you should use only medications that add benefit and are low in side effects. Now, who can tell if medicines are effective and low in side effects? Only you can. So it's really important that you partner with your clinician and give very good feedback. Observe your pain before and at stages after initiating a treatment, and also record and pay attention to any side effects that might occur in your particular case, because it is up to you to observe and communicate what happens when you try medications. Use the lowest effective doses, and over time, see if you can gradually replace some of your medications with lifestyle changes and see how low you can get the burden of polypharmacy. Some people need to stay on certain medications in order to have adequate pain relief. So this slide is to plant the idea that sometimes you can pick a medicine that does more than one thing. For example, duloxetine, that's Cymbalta, is a medicine that's it helps depression and anxiety in many cases, but it also modulates hyperalgesia and may reduce that. So if you're a person who needs to be on an antidepressant or something that helps with anxiety and you also have pain, it makes sense to choose one drug that might provide benefit in two areas of symptom management. The same is true with sleep problems and hyperalgesia. If you have horrible sleep and pain-disrupted sleep, or anxiety-disrupted sleep, sometimes drugs like anticonvulsants or tricyclic antidepressants make the most sense, because with a single drug, you can treat sleep and you can reduce the hyperalgesia. So having these discussions with your medical providers is very productive in achieving the best management for you and reducing the risk of side effects from too many medications. People respond in various ways to medications. So really, it's your experience with a drug that will ultimately determine its usefulness for you. I want to show you, using research in gene expression, how the effects of trying a drug, in this case Lyrica, are completely different from one subject to the next. I won't take the time to tell you everything about gene expression studies, but I will tell you that at baseline, the patient this is before exercising on a bicycle, and we consider the level of the expression of a number of genes to be 0 at this point. Then the patient exercises for 25 minutes on an exercise bike. The blood is then drawn 3 more times, 8 hours later, the following morning, and again the third morning. So, for example, the blue bars you can see under subject LYR06 are an increase in gene expression after exercise that was measured on each of those blood draws. And you can see that there are some genes that downregulated as a result of the exercise as well. What's interesting is that when normal people exercise, their gene expression is much milder, as though their body doesn't have to respond and repair and react so vigorously to simply doing the exercise. Another thing that's interesting is those light blue lines are the expression of new receptors that are related to pain transmission. So you can see that the subject had an escalation of genes that relate to an increase in pain from the exercise. Now this slide shows the patient who enrolled in a trial with two exercise efforts with gene expression. One was on Lyrica, and the second was off Lyrica, or on placebo. And the patients were blinded as to whether they were on placebo or drug. So on Lyrica, you can see that those blue lines do not occur after the exercise. And so on the left is the gene response when the patient was on Lyrica, and on the right is the gene response after exercise when the patient was on placebo. So you can see that those blue bars went up, and indeed this patient experienced more pain from the exercise, and when he was on Lyrica, he did not experience as much pain after engaging in this activity. In the next slide, this is a different patient, but a similar result. So this is patient number 11. On Lyrica, after exercise, there's activity, but compared to when the patient was on placebo, you can see that on placebo after exercise, the blue bars go up, which are associated with the development of pain from the exercise. So this is another patient that felt better when they were on the Lyrica, and also had a better capacity to exercise without inducing pain or other symptoms. This is a graph of that patient where we individually look at the symptoms before, during, and after the exercise. The pink line on top is the mental fatigue before, during, and after exercise on placebo, and the lower line is mental fatigue before, during, and after exercise when the patient was on Lyrica. And you can see that the patient started with a lower baseline of mental fatigue, and even though it did rise on day 2, it was much improved from not during the test that was done when the patient was not on Lyrica or on placebo. So those are two patients that were good candidates for the use of Lyrica to treat their hyperalgesia. These are the same patient showing the benefit to physical fatigue. Again, the top line is when they are not on Lyrica, and the bottom line is when this subject was on Lyrica. Here are the pain scores, off Lyrica on top and on Lyrica on the bottom. So this person started out with a lower pain score, had a slower rise in their pain, and did not have as much rebound pain from doing the exercise test when they were on the arm of the study where they took Lyrica. So subject 12 had the opposite response to Lyrica. You can see in the mental fatigue, the physical fatigue, and the pain ratings that when the patient was on Lyrica, that's the darker circles on top, it may be a little difficult to see, everything was the same or even worse than when the patient was on placebo in the other arm of the study. And this was a patient that did not feel better on Lyrica. In fact, this slide compares the gene responses of this patient while on placebo to when this patient was on Lyrica. And you can see that after exercise, on placebo, the bars go down, but after exercise on Lyrica, the pain and the other gene expression bars get worse. And this patient felt worse when he was on Lyrica, and after exercising, you can see those same blue bars. So this is a person that would, say that Lyrica was not a drug that helped them. Now, unfortunately, this is not a test for prime time. This is a test used in research. I'm using this to tell you that it is within your observation to determine if a drug is useful for your pain and to give feedback to your clinicians if the drug makes you feel worse instead of better. So here is Lyrica, the patient number 12 on placebo. You can see their response was different than the control subjects. He still has a disease, but when he wasn't on Lyrica, he did not have that pain response to doing the exercise. And here it is again showing him next to controls on Lyrica with the big pain response compared to the normal people who underwent exercise testing. Now, if you look on the right side of this slide, I've drawn some horizontal blue lines. This is to point out the different genes that we were looking at in this study. The top three are genes involved in the production of of receptors that involve pain and fatigue signaling in the body and in the brain. The middle few are what we call adrenergic receptors, or receptors that are involved in the sympathetic nervous system, part of your autonomic nervous system, your fight and flight response. And those on the bottom are cytokines, or some messengers of the inflammatory system that show that there's a process of inflammation. All of the slides I showed you so far looked at just those genes after exercise. However, later, Dr. Light and his colleagues tested additional genes to expand those categories and add additional genes to see how they would be affected by the exercise, and specifically how being on or off Lyrica might affect these genes or the expression of these genes. So in this slide, I want to show you subject number 12 on placebo, on Lyrica, and compared to controls. And all the genes that were looked at on this graph relate to the signaling of pain and fatigue. So this is the patient again that seemed to have worse signaling in his sensory system when he was on Lyrica compared to when he was not. Here is that same patient on the left. And all of these graphs now are showing the expression of genes related to your sympathetic nervous system. Look at the controls on the right. Look at the patient on the far left when he's on placebo. And you can see that in the middle, after exercise, when he was on Lyrica, he had a very different pattern of gene expression, suggesting there's something very wrong with his sympathetic response to the exercise. And it's worsened by the presence, or even created by the presence, of the Lyrica. Here is patient 12 when we look at his immune and inflammatory genes. And remember, this is the expression of genes, so it's your body trying to make new product based on your genes to replace or augment or recover from something that happened. Again, the controls are on the right, the response of gene expression to exercise. On the far left are our patient number 12 when he was not on Lyrica. And in the middle, you can see a much more dramatic response of immune and inflammatory genes as a result of exercise when on Lyrica. Here are HPA axis and stress genes. These are genes that are involved in helping you recover or deal with the normal response to stress in your body related to cortisol and all the pathways. So you can see on the far right the response that the control patients had to exercise. On the far left, the response our patient number 12 had to exercise when he was not on Lyrica. You can see the little bit different pain response, but the bars still go up. And when this patient is on Lyrica, he has a very aberrant response related to his HPA axis and stress genes after a bout of exercise. These are mitochondrial genes that were examined in this patient. On the right are the control patients and the expression of those 5 mitochondrial genes after exercise. On the far left are the expression of this patient who was on placebo in the first arm, and again in the middle, this patient was on Lyrica, and you can see that the expression of mitochondrial genes is altered also by the presence of Lyrica. So in summary, I want to say that many people respond to Lyrica, and it's a very valuable medication for pain and for hyperalgesia in many patients, which is why it became FDA approved. But you should be aware that this suggests that some people have a different kind of underlying physiology, and if you feel worse on Lyrica, more tired, less able to exercise, and maybe no pain relief, then it would not make any sense to continue on Lyrica. So in summary, remember these important basic principles for the management of both ME/CFS and fibromyalgia. First is you need to work with your medical providers to be sure that you have identified and are carefully managing any other illness that might be contributing to the symptoms. And this might be true in the beginning of a workup, but at intervals or any time your situation and presentation of symptoms changes in pattern. Second, and this is really the first rule of management of these illnesses, you need to learn to pace your activity. And that means instead of just doing until you crash, understand where your limits are. Understand where pain begins to escalate. Understand when you're going to develop relapse symptoms, and try to stop your activity or spread your activity out in small increments to avoid the escalation of pain or the production of post-exertional malaise. And then remember these table legs and how pain fits squarely into an important table leg. And here it is visible for us. I like to look at the table leg, and the top of the table is chronic unwellness and your well-being. And the front 3 legs of this table that firmly secure the table's balance are restorative sleep, pain reduction and management, and anything that helps your mental well-being. When those things have become more stable, including orthostatic intolerance if it's present, then you can develop the right kind of fitness and conditioning as your body and for your disease severity in a close relationship with your helpers and providers. But remember that pacing and activity management is first. Thank you and good luck. I hope this information has helped you learn more about chronic pain, the varieties of chronic pain, and how to go about management. The more you know about your illness and your pain, the more you'll be able to partner effectively with your medical providers. This lecture is one of 6 that we've been teaching at the Bateman Horn Center in a live class where patients come and attend the class. Most of these patients are people we were not able to get into our clinic for medical management. So we're offering these classes as a way of helping you learn more about your own illness and how to become empowered to talk with your medical providers. I want to tell you that the other classes that we have available online, one is getting and making the right diagnosis. 2 is activity intolerance, pacing, and post-exertional malaise. 3 is sleep disturbances. 4 is cognitive impairment. And the 5th lecture, in addition to our pain lecture today, is a lecture on orthostatic intolerance. Hope to see you there.